On behalf of NNF Gujarat, I, Dr. Prashant Karya, Secretary of NNF Gujarat, welcomes one and all to today's Neonatal Pathshala. Today we are having a PG case presentation, and for the same, I invite our President, Dr. Sandeep Trivedi, to welcome one and all.
Thank you, Prashant. I welcome Dr. Ruchi Madam, Dr. Arsad Sir, and Reshma Ben, and also today case presenter Jaimin. And this is the Neonatal Pathshala is the one of the best program for the PG student as well as pediatrician and also neonatologist who are going to work in neonatology. Thank you, Prashant. Hand over to Prashant.
Thank you so much, Sandeep bhai. Today we are having a case presentation by Dr. Jaimin Patel, and same has been prepared by under guidance of Dr. Reshma Pujara. Dr. Reshma Pujara is chairperson for today's session. She is the assistant professor in Department of Pediatrics, Sri Krishna Hospital, Pramukh Swami Medical College, Karamsad, and she is also a member of Royal College of Pediatrics and Child in London, UK. Her special interest is in breastfeeding, KMC, and she is also advanced NRP trainer. So I welcome Dr. Reshma Pujara to introduce today's experts.
Thank you, Dr. Prashant. And thank you very much, Sandeep sir, Dr. Prashant and Somsekhar sir for giving me this opportunity to chair this session. So without wasting much time, I would like to welcome our faculty for today's session. First, I would like to welcome Dr. Ruchi Nanavati Madam. Madam is an emeritus professor of Department of Neonatology, Sheikh GS Medical College and KEM Hospital, Mumbai, and she has remained the professor as well as the head of the same hospital. She is also currently a trustee of one NGO called Society for Nutrition, Education and Health Action. She has remained president for National Neonatology Forum Maharashtra State Chapter, and she's been worked as a president, vice president, as well as secretary for NNF Mumbai branch. Madam has contributed with multiple guidelines for COVID as well as KMC for the Ministry of Health and Family Welfare, Government of India. Madam has received multiple awards, including Lifetime Achievement Awards, and she's received nearly 13 gold medals at the national conferences for the research in the field of neonatology. Madam has n number of publications at national and international journals, as well as she has written chapters for various books. So welcome, Dr. Ruchi Nanavati.
Yeah.
Now I would like
thank you very much. Thank you very much.
Yes,
yeah.
Now I would like to welcome Dr. Arsad Siralar. Sir is a senior pediatric consultant at MGM Healthcare. He is also head of the Department of Pediatrics and Joint Dean at ACS Medical College, Chennai. He is a professor of pediatric at Madras Medical College, Chennai. And in 2009, he's remained as a vice president of IAP-CCB. He's remained worked as a secretary NNF Tamil Nadu State branch, and currently he is a president-elect at National Neonatology Forum, Tamil Nadu State for 2022-23. Welcome, sir.
Welcome.
I would also like to introduce to all of you Dr. Jaimin Patel. Dr. Jaimin is a postgraduate student of Shri Krishna Hospital, Pramukh Swami Medical College, Gujarat, Karamsad. After finishing his post-graduation, he has joined our department as a neonatal fellow. He's been working with us since last 9 months, and he's the presenter of today's case. Welcome.
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 Now I'll hand over to Dr. Prashant sir.
Without taking much of a time, I request Jaimin to start the case presentation.
Yes, sir.
Request to all participants to switch off their videos, except for the chairpersons and the faculty members and the student. Thank you.
Sir, should I start?
Yes, Jaimin.
Good afternoon to all.
You can start, Jaimin.
Ma'am, slide is not moving.
Jaimin, click on the screen and then the slide will start running.
One second, sir. Okay.
Yeah, it's running.
Presenting a case of 9 days old female newborn of XYZ, 37.2 weeks, born by lower segment cesarean section due to CPD with breech presentation on 26 April 2022. Birth weight was 2.2 kg. Post menstruation age is 38.4 weeks. Informant is mother. Baby was referred to our NICU at 26 hours of age in a view of delayed cry after birth and difficulty in breathing since birth. Antenatal history. Mother is 28 years old, primary gravida, active marriage life of 1 year. Pregnancy was diagnosed with a urinary pregnancy test at a private hospital. LMP was 9th August 2021. EDD was 16th May 2022. Pre-pregnancy weight was 38 kg. Mother blood group is O negative.
Can we ask the questions? Just tell me, the significance of pre-pregnancy weight of 38 kg. When taking history, and if you get the history of pre-pregnancy weight 38 kg, what are the things you should, what comes to your mind?
Ma'am, basically, if pre-pregnancy weight is low, there is a higher chance of low birth weight babies, IUGR babies, and also there is a chance of abortions if mother's nutrition is not adequate.
Yeah, okay. Any further details will you like to know? This is what you said is correct. So anything else? How do we look at, means when the mother's weight is say 38 kg, you also have to know that how much do you expect her to gain during pregnancy?
Yes.
So can you talk about that?
If mother is underweight before the pregnancy, she should have a weight gain of approximate 12 to 16 kg during the pregnancy. And if mother is obese, then it would be preferred that it would be weight gain of approximate 8 to 10 kg. And on an average, in India, there is on an average weight gain was 8 to 10 kg during the pregnancy.
No, that is okay. Means what you're trying to say is, for the benefit of others, is that it depends upon the body mass index, right? So if the mother is undernourished and, her body mass index is less than 18.5, then the mother will require as high as almost about 12 to 18 kgs she has to gain during the pregnancy to have a baby with a normal weight. While if the she is obese, as you said, she requires, say about 6 to 9 kgs to have this thing, so that there is an importance of, the pre-pregnancy weight. So you said correctly, go ahead. Yeah.
Okay. First trimester history. Mother was booked at a private hospital and taken regularly antenatal visit at monthly intervals. She tested negative for HIV, HBsAg, VDRL. Folic acid was taken regularly. First trimester scan was normal, but the report is not available. No history of fever, rash, hypertension, diabetes, thyroid. Mother's HB was 11 gram per cent. Second trimester history. Quickening was felt from 5 months of amenorrhea. Both iron and calcium tablets were taken regularly along with folic acid. First dose of TD was taken at 16 weeks of gestation. Second dose of TD was taken at 27 weeks of gestation. Anomaly scan was done at 22 weeks of gestation, which was normal. No history of PIH, gestational diabetes mellitus, or anemia. Third trimester history. Antenatal visits were taken every 15 days nearby government hospital and mother's weight was 50 kg. Third trimester USG scan and Doppler was done at 36 weeks of gestation, which was normal, and estimated fetal weight was 2312 plus minus 346 grams. No history of fever, burning micturition, conversion, foul smelling discharge, leaking, or bleeding per vagina. Perinatal history. She underwent elective lower segment cesarean section under spinal anesthesia due to breech presentation with cephalopelvic disproportion at 37.2 weeks gestation. A full-term live baby girl was delivered at 5:30 p.m. on 26 April 2022 at a government hospital. Postnatal history. As per referral note, baby did not cry immediately after birth, above not mentioned. Baby cried after initial steps of resuscitation. Baby was transferred to a private practitioner for further management. At 2 hours of life, baby's saturation was 60% on room air, RR 76 per minute with grunting, poor pulses and fair activity. Baby was kept on nasal CPAP, IV fluid and IV antibiotics. Piperacillin, tazobactam and amikacin started. Blood investigation said suggestive of hemoglobin 17.3, total WBC count 20,500, platelet 361,000, CRP 4.3, blood gas not done. As the baby did not maintain saturation on nasal CPAP, baby was referred to our hospital. Hospital course. We received the baby at 26 hours of life. Fair activity, respiratory distress, Downey score 5/10. So the baby was kept on TB's resuscitator and P5 with oxygen. Random blood sugar was done, it was 34 milligram per dl. So injection 10% bolus was given. Baby was transferred to NICU with TB's resuscitator and kept on nasal CPAP if 6 F5 to 40%. On arrival, Thompson scoring was done. It was 8/22. Mild HI, lethargic +2, hypotonia present in all 4 limbs +2, poor suck +2, poor grasp +1, and hyperventilation +1. And at the same time, Sarnat staging was also done, which was in stage 2, lethargic, mild hypotonia, weak suck, pupils bilateral reactive to light, 1 mm, and profuse secretions. This was the comparison of the modified Thompson score between the modified Sarnat staging, which was the one of the study from Journal of Perinatology. It suggested that if score is 0 to 4, then modified Sarnat staging is normal. If a correlation, it is a basically correlation of Thompson score and modified Sarnat score. If 5 or 6 score, then mild HI according to modified Sarnat staging. If score is 7 to 13, then according to modified Sarnat staging, there is a moderate HI, and more than or equal to 14, then there is a severe HI.
Tell me now, since you have gone into the details of this, tell me why it is important to differentiate between mild and moderate, mild and moderate HI. So there are actually few questions. That why do you think this baby received CPAP at a private institution? What could be the provisional diagnosis? Why have they given CPAP, you think?
Ma'am, basically, baby did not cry after birth. Okay, right. and baby was taken elective cesarean section. Though there is a one thing is there is a baby has a history of perinatal asphyxia. Also associated, there is possibility of respiratory distress due to the TTN, transient tachypnea of newborn.
No. Suppose if the baby, has not cried at birth, so there are certain details you require. Is that what was the form of resuscitation the baby required at birth? Because the baby didn't cry at birth, right? And then, the baby, there was LSTS that is accepted, which was done for breech. So are you going to say that this case is because of TTNB?
No.
Yeah. So, when you have received the baby at 26 hours of life, your first thing is that this baby has received CPAP. What could be the, why have they given CPAP? What could be the etiology? That is one important thing.
Yes.
Second thing, you also need to answer that what was the indication for giving this baby antibiotics?
Basically, ma'am, in outside private, they started prophylactically antibiotics. There is a
yeah, so the prophylactic
yes,
antibiotics are not indicated.
Not indicated in perinatal.
There is actually no such concept as prophylactic antibiotics.
Yeah, there is nothing.
Yeah.
So only because someone has started, there is no need to continue. The antibiotics. Yeah. And you have to have a working diagnosis that, now this baby has come to you, on CPAP. He has received it for almost about 24 to 26 hours and the baby has not improved. Then why did you continue as a TP's resuscitator? Why didn't you, that was not sufficient for the baby. So why
Yes.
did you do TP's resuscitation? That is a question,
Ma'am,
right? Then we will come to Thompson score. Yeah.
yes, ma'am. Basically, we gave for brief duration 1 to 2 hours, and as baby was worsening, we intubate the baby and kept on mechanical ventilation at 2 hours of life.
So what
2
was
hours
your
of,
yeah
2 hours of admission.
yeah? But when you gave the TP's resuscitation, through this, what was your working diagnosis?
Ma'am, basically, at the full term baby, the history
Precisely.
of perinatal asphyxia, which may be due to there is a chances that there is a before 24 hours baby could not receive the adequate ventilation, so there is a chances of
No, they have given CPAP. They have given
yes.
CPAP to the baby. So actually, when you receive this baby, do you consider this as a CPAP failure?
Yes.
Yeah.
Ma'am, because baby was transferring from outside the hospital, which was were transferred on the nasal prongs without CPAP.
But baby has received CPAP there, no?
Yes.
So, for 24 hours, and the baby has, not responded. So do you think that this baby, first you have to look into the cause, that why the baby has this thing, and you have continued CPAP for the child. So whether, do you like to consider anything else at this stage?
Yes, ma'am.
Yeah.
One thing is a pulmonary artery hypertension. There is a possibility of PPHN due to the perinatal asphyxia. One thing that due to which there is a distress and patient is not maintaining saturations.
Now, this case, Jaimin,
Yes, sir.
2-3 things. This baby has started crying by initial steps of resuscitation, which means just tactile stimulation and just probably airway clearing at the most, which means the asphyxial component is not severe. So you cannot attribute all of this, your clinical findings, to a mild asphyxia. Okay. A baby that gets revived on its own with only tactile stimulation would have an Apgar score roughly, probably because it has started breathing within 30 seconds, according to you, which means by initial steps. Okay. Not requiring positive pressure ventilation is a mild form of asphyxia, which cannot probably explain all of the clinical findings that the baby is exhibiting, neurological finding. 2, in the antenatal history, I think you have told this mother is O negative, huh?
Yes, sir.
Now, is the in a O negative pregnancy, do you want more histories?
Yes, sir. We should ask regarding the previous pregnancy. What is the blood group of baby previous pregnancy? And if a mother is not taken NTD, then we should give the NTD 300 microgram. And another things, if in current pregnancy, if
you need to know the blood group of the husband
baby.
also. Yeah, you should have asked the blood group of the husband.
Husband also.
You should have had if this is a first pregnancy for the mother. So we do not we only want not the previous pregnancy, but previous any abortions and whether it was protected by anti. Huh?
Yes.
That history you should have asked and put it there. Huh?
Yes.
Okay.
Yeah.
See this. You were anticipating this baby is in SGA.
Yes.
No? But PPHN is common with IUGR rather than with SGAs alone.
Okay, sir.
Okay. So, but you expect a small baby with a mother only 38 kg and you are not mentioned the height of the mother. So that is also one important anthropometry like weight, which would give a better outcome what baby you probably will get. That would explain the anthropometry of the baby that you have highlighted also. Huh?
Okay, sir.
So put the height of the mother also there, whether it is within the standard recommended weight and height that is recommended for our pre-pregnant women. Huh?
Yes, sir.
Yeah. Now tell us why at birth it is important to differentiate between, this baby came to you at 26 hours, accepted. But why after birth it is important to differentiate between mild and moderate HIV?
Ma'am, basically there is a very important that there is a if baby had a mild HIV, it is a good neurological outcome, and baby
No. I'm listen to my question. I'm asking from the point of view of management of the child. this thing. Why do you prognosis is subsequently? Okay. So of course you will counsel the relatives and everything, but from your decision making point of view, why do you want to differentiate between mild and moderate HIV is a question.
Basically, there is a difference in treatment. If there is a moderate to severe HI, then there is we should consider the therapeutic hypothermia to
precisely. So that is very important, that if it is a moderate HI, so you will and this baby is a 37 weeker. So yes, depending upon this baby can be means of course if it actually has a moderate HI, then this baby, depending upon satisfying the criteria whichever you are using, that or as per our NNF guidelines, position statement is out that this baby could be means probably was a candidate to get therapeutic hypothermia. So all these details which are there at admission, has to be, you have to get those details from the referring hospital. Okay, yes, fine. Yes, yeah, go ahead. Yeah.
Vitals on arrivals, temperature normal, pulse is well palpable, respiratory was 70 per minute, CRT was 3 seconds, saturation was 92% on FiO2 to 40% on CPAP, umbilical artery and venous catheterization were done and blood investigations were sent. IV fluid along with calcium gluconate started in maintenance dose due to low calcium in ABG. Due to deranged coagulation profile, 1 unit of FFP was given. This was the serial ABG in which there is a lower side of the ionized calcium. Cranium.
Yeah, go back.
Yes, ma'am.
Go back and interpret one ABG.
Yes, ma'am. Basically, these all ABG are normal because on arrival, pH is 7.41, PCO2 35, and ma'am, bicarb
interpret the last ABG. Do you think the last ABG is normal?
Ma'am, last ABG, pH is 7.28 acidic. Then PCO2 is a 52, which is a slight higher side, the respiratory acidosis, and bicarb is a 24.4. So this is a respiratory acidosis, and
so what happens to bicarb in respiratory acidosis?
Ma'am, bicarb is increased while the compensatory acute respiratory acidosis. Bicarb is increase 1 MEQ for increasing the 10 mmHg of increasing the PCO2.
Okay, there is a, so how, what is this? So how will you interpret finally this ABG? So for every 10 rise in, your carbon dioxide in an acute disorder, it will increase by about 1 to 3. It's a range. It's not only 1. It's 1 to 3. And so now here the carbon dioxide is increased by 12. So how much, what bicarb do you expect?
Ma'am,
so you have to diagnose, whether you require to, act on it. It's a different question. But what is your interpretation of this ABG?
Ma'am, respiratory acidosis with compensatory metabolic alkalosis.
Is it? So it's a compensated disorder or partially compensated disorder? Do you think there is metabolic alkalosis?
No, ma'am, because pH is 7.
So what is this ABG?
Ma'am, mixed acidosis.
Mixed acidosis. Is there bicarb 24.4? Is it suggestive of acidosis?
Ma'am, bicarb is a normal value is 22 to 28. And 24 is the median.
So it's normal, no?
Yes, ma'am.
And you can look at base deficit also is -2.
2.
Yeah. So there is, so this is actually partially compensated respiratory acidosis, right? Now, why do you think this baby has acidosis? Your interpretation of ABG is that it is partially compensated respiratory acidosis. That is the interpretation of ABG. But you have to ask the question, why is this baby having respiratory acidosis? So what do you think? Why was the baby having respiratory acidosis? At
CO2 retention basically is due to the when the ABG was done on 13th April, there is a PCO2 is a retention. So there is a respiratory CO2 buildup is like respiratory baby in respiratory failure, increasing. Ma'am, basically PCO2 increasing if hypercarbia is present in the EBG, it is suggestive that PB is progressing toward the because
see, you understand, no? What I'm trying to ask you is that increase in carbon dioxide is a manifestation of underlying disorder, right? Something
yes,
is there, that's why the baby has carbon dioxide, and it's not significantly increased. It is, what is the mean carbon
because
dioxide?
tube blockage or there is a secretions, then there is a chance there.
That is one of the possibility. What was the cause? If you look at the various causes, is one of the thing, but anything else pathophysiologically,
ma'am, baby has a no spontaneous breathing, so there is a chance
that the baby was no spontaneous breathing. You said the baby required only till 30th of April there was no spontaneous breathing.
Ma'am, baby had a spontaneous breathing, but baby required the mechanical ventilation.
No, means was there hypoventilation? Means was there, how was the spontaneous respiration of the baby? There was no spontaneous respiration?
No, ma'am, spontaneous respiration is present, but not all respiratory rate 30 to on ventilator there is a 30 to 40 respiratory rate.
Ma'am, Jaimin, madam is trying to ask you that why there is this respiratory acidosis. So what could be the background pathophysiology behind it? Considering this baby's presentation who had suffered some perinatal asphyxia, what could be the possibility? And you also have to look into the ventilatory parameters, na? From 27th to 30th, what were your ventilatory parameters? So you were gradually weaning the ventilation, and there, what was the problem with the baby while you were weaning?
Jaimin?
Yes, sir.
To interpret this, ma'am simply correlated with the clinical status at the time, the ventilatory settings and the clinical status. Then probably you will understand why this respiratory acidosis has come.
So it was more of a baby with hypoxia who had a poor respiratory drive. Along with that, you were weaning, so and baby was having multiple thick secretions. There was a one point where tube was blocked. So there were multiple causes: the clinical condition, ventilatory parameters, background cause, which could affect the baby. The main reason this baby needed ventilation in initial hours of life was because of the inadequate transition. Because of the HI, baby had not had smooth breathing after birth.
Okay.
Okay, we can ask him to proceed, I think.
USG cranium done on admission, which was normal. Functional 2D echo, which was suggestive of fair cardiac activity and moderate pH. So injection dovitamin drip was started. As respiratory distress worsened, Downey score 6/10, along with seesaw breathing. So the baby was intubated at 3 hours of admission and kept on mechanical ventilator. SIBPV mode, PIP 18, FIO to 60%, PEEP 6. This was the X-ray. First one X-ray is from outside, and second one is X-ray after the intubation of the baby.
So what is your inference? Interpretation of this X-ray?
In sir, first X-ray, there is a around the perihilar lesion, there is a sunburst type of pattern present, and the other part of the lung is clear.
Prominent hilar. Yeah.
Yes, prominent hilar, sir.
Is there peripheral pruning also?
Yes, sir.
Yeah. So what does that indicate? Again, your pulmonary hypertension only. That's
yes.
Yeah.
Yes, sir.
Okay. Are the lung markings clear, or it's slightly showing poor aeration?
Sir,
when compared to the X-ray taken at your center, the first X-ray taken there, it is showing
Yes.
good aeration of lung tissue.
Yes, pardon, sir.
Aeration of the lungs, ventilation of the lungs.
Yes, sir.
You could see a very fine granular patterns there.
Yes,
Very
sir.
fine. Yeah, when compared to the one that is taken where ventilation probably has improved better.
Yes, sir.
Yeah, okay. Good.
Baby was kept NBM for 24 hours and then minimal enteral feeding via infant feeding tube was started and gradually increased. Based on the normal sepsis screen and no growth on blood culture, antibiotics were omitted on third day of life. As respiratory distress resolved, Ventilatory parameters were gradually tapered. USG cranium on 7th day normal. On 8th day of life, as baby maintained the saturation on minimal ventilatory parameters, the basic baby was extubated and kept on nasal CPAP. This was the mode of ventilation according to day of life, and on 8th day, baby was intubated and kept on nasal CPAP.
So it would have been nice if you had put the ABG correlated to this. Then the interpretation would be better.
Yes, sir.
So that at the time the year is day 7, there you have put the dates. So we are not able to correlate what was the 7th day. That is, you have put as day 3. No, month date as 3.
Sir,
so it would be better you follow the same thing, either the days or the day. Your parameters also, and also specify on what mode of ventilation it was there, so that we know what probably would be the cause.
Yes.
That you need to anticipate and correct.
Yes. Sir, the 13th ABG, which was on day of like 5th.
Day 3.
Day 5th, sir. 5th.
Day?
5th. Day of life 5th.
Day 5th. Okay. Still when it was on mechanical ventilator.
Yes, SIMV plus PSV.
So you have stopped doing ABG after that.
Yes, sir. Sir, last ABG was done today, which was normal, but I cannot put on the presentation.
Okay, fine. Okay, good.
Okay. Sir, serial monitoring of Thompson score was done, which shows the improvement in baby's condition. Currently, baby on nasal CPAP maintains saturation well, tolerating full OG feeding with adequate urine and stool output. These are the blood reports of the baby. We shows the PTINR derangement on 27th April, and there is a lower side total calcium on 29th April, and there is a borderline raise of CRP on 27th April. Otherwise, septic screen and blood culture is normal subsequently.
Do you give any significance to that CRP?
Sir, basically, septic screen, this was the septic screen after 24 hours. According to septic screen, there is a absolute low absolute ANC count. Second one is increase more than one more than one CRP, more than 15 mm micro ESR at 1 hour, and sir, IT ratio is more than 0.2.
Okay. Is the CRP rise, mild CRP rise, a surprise to you? You want to put it as a probable sepsis or just ignore it?
Sir, basically, sir, we could continue at that time antibiotics until the blood culture reports came on 3rd day of life.
What day of life is that? 27/4?
27th is the sir, 2nd day of life. 26th is a born. 27th is
the previous CRP was 5, no? At the time you received was 5. So you have seen 9.4 here.
Sir, 27th on receiving day on our hospital on 2nd day. And sir, subsequent on 29th, we again repeated. At the same time, blood culture is also negative. So we stopped the antibiotic on 29th April.
Oh, okay. Is the creatinine level normal?
Sir, slightly higher side.
It's on the higher side. Okay. Good.
Family history, no any history of neonatal deaths, and upper lower socioeconomic class according to modified Fukusami classification. Summary: a full-term girl baby of weight 2.2 kg born by LSCS with history of perinatal asphyxia and severe respiratory distress at birth. requiring invasive mechanical ventilation with mild to moderate HI, moderate pH, deranged coagulation profile, asymptomatic hypoglycemia.
So what do you think the cause for this respiratory distress? Again, madam had actually asked this question before. What do you think probable cause for the respiratory distress? In a child where nothing, no problem is anticipated, it's only an elective LSCS. An elective LSCS, why should it become asphyxiated? So what does it indicate? If an elective LSCS, you find it asphyxiated, where do you think the problem is?
Sir, actually, problem is in third trimester when there is a mother. One thing is as per mother, there is a brief presentation, and another thing is a CPD. Mother told by that private.
It only indicates poor intrapartum monitoring.
Yes, sir.
Okay.
Yes.
So in elective LSCS, if you forget to monitor, thinking everything is all right, from the night when you are keeping the mother nil oral till morning LSCS in a government setup, this is what happens. Mother could have gone for hypoglycemia. Mother could have gone under fear and stress of LSCS. That has a bearing on the asphyxiation. Most of times, these elective LSCS are not monitored in the intrapartum period, thinking there are no risk factors. Here, the only risk factor probably that has made them decide was CPD, short mother, no, underweight.
Yes, sir. Yes.
And they have ended up with an asphyxiated baby. So the very purpose of elective LSCS, with not anticipating an asphyxiated baby is going to come.
Yes.
So what is the cause for this? Can the asphyxia be, this mild asphyxia be the cause for respiratory distress? Or respiratory distress could be, is there any entity that respiratory distress problem that you can get in elective LSCS?
Sir, two possibility. One thing is first is maybe due to the perinatal asphyxia, and later
unlikely because mild perinatal asphyxia, it would not have caused much organ damages, including lungs.
Yes. Second possibility is one thing is due to respiratory distress is due to the LSCS, as baby is term born by LSCS. And there is a
what do you call that?
Transient TTN, sir.
No, these are LSCS that comes without labor pains. Okay, you have to be very careful. There is a specific entity in an elective LSCS born with labor pains and born without previous labor pains. The one born without previous labor pains has got an higher incidence of getting into respiratory distress, like akin to ARDS.
ARDS.
And the morbidity and mortality there is very high. And they also fail to respond to even surfactants.
Yes.
Okay. So maybe it is one of those cases.
Yes.
Yeah. Okay. Sorry, I lost the connection for some time. I just want to know that, see, TTNB is, the baby who is not cried at birth. You don't know what resuscitation the baby has required. And then this baby has respiratory distress. You are not going to label it as TTNB. Okay. Now, whenever the babies have, this the poor, poor respiration, or the delayed cried, or whatever you say, the babies, can they have the respiratory distress because the respiratory efforts are not strong and there is a delayed absorption of fluid? That is one of the possibility. With asphyxia, the baby can have even something. Of course, this asphyxia, you don't have the details. By the time 26 hours the baby came, you said the baby has probably, doesn't appear like a severe asphyxia, as doctor has said. So you don't have a very clear cause. It doesn't look like asphyxiated lung or anything. And the X-ray also showed relatively, the normal parenchyma, that there was not significant, at least one of the X-ray was a little overexposed, but you don't find significant parenchymal, disease here. So the question is, the baby also had associated your pulmonary hypertension. So whether that was responsible for the thing, I missed your, the echo findings, what you said, and how much was the, pulmonary hypertension. But this, sort of delayed efforts, the babies, this thing, the associated pulmonary hypertension, and that everything could be responsible that this baby having, the respiratory distress or whatever at birth. and the baby also improved, subsequently within a period of about, he required mechanical ventilation for how long?
Yeah.
He required mechanical ventilation?
I think 4 days they had kept on mechanical.
Hello?
4 days.
How long totally did he require mechanical ventilation?
6.
1, 2, 3.
Ma'am, 7 days. 7 days baby required the mechanical.
Okay. And then significant means, his requirement came back. Okay. Yeah. But, you look at subsequently your whatever parameters you are giving are even PIP just 13 and 12, So it's not, so that all tells you, if you look at the babies, the respiratory parameters, just go to the one slide before.
Yes.
One slide.
One slide before. See, when you look at the babies, the ventilatory parameters, and when you are looking the PIP of the baby, see 16, 14, 13, 12, that tells you, that itself tells you that, the parenchyma is not bad.
Yes.
So, yeah. So whatever ventilatory support this baby has required is not significant. Only thing, so you had to look at how good was the baby's spontaneous respiration. And if this baby's spontaneous respiration was good, then this baby could have been given a non-invasive ventilation. It's not that you have to keep the baby intubated, Otherwise, we are predisposing them for a lot of, injuries related to ventilation. What are these injuries related to ventilation? What they are called as? Have you heard of?
Ma'am,
what is villi? No, what is full form of villi?
Ventilated initiated lung injury.
Ventilation, so what is villi?
Ma'am, barotrauma, volutrauma.
So which is, what is, which trauma is more sort of dangerous for the babies? These ventilation induced lung injuries, which are the different ones? Just name them and tell them and tell us what is you are most worried about. Of course, yeah, tell us.
Ma'am, barotrauma due to increase the more pressure, due to giving more pressure.
Okay, go ahead. Next, because we don't have time. Next.
Yeah, present.
Okay. Hyatt examined the baby 2 days with proper aseptic precaution and with consent of the mother. Baby is carried under a servo control format. Temperature probe attached on right lower part of chest. Saturation probe attached on right hand. Umbilical artery and venous catheter in situ on nasal, and baby was on nasal CPAP. P5 FI to 25%. Temperature is 36.8 degrees Celsius. Heart rate is 140 per minute. Periphery and central pulse is well palpable. CRT is 2 seconds. Blood pressure right upper limb mean 46 mmHg. Right lower limb mean 49 mmHg. Respiratory rate was 56 per minute. Saturation was 94% on right upper limb, 96% on left lower limb. No pleural icterus cyanosis or edema. Anthropometry weight was on admission 2.2 kg. Expected was 2.6 kg, which was between 3rd to 10th centile. Length is 44 centimeter. Expected is 47.5 centimeter, which was on 3rd centile according to Intergrowth 21 charts. Head circumference is 32.5 centimeter. Expected 32.5 centimeter, which was on 50th centile. Intergrowth 21 charts, and head circumference on 9th day of life is 33 centimeter. This was the plotting on Intergrowth 21 charts, which shows the head circumference on 50th centile, length on the 3rd, and birth weight is on 3rd to 10th centile at 37.2. Head to toe examinations. No swelling overhead. Anterior fontanelle 2.2 centimeter open at level. Posterior fontanelle just tip of finger administered. No facial dysmorphism. Red reflex bilateral normal. Ears normal in size, shape, and at position. No cleft lip, palate. No any birthmarks or injuries. Nose, nasal septum, ala bridges appear normal. Neck, no swelling over the neck. Umbilicus line tracings present over abdomen, no polydactyly, syndactyly, back and spine normal, anal opening present and pattern, genitals normal, bilateral hip examination normal. Systemic examination. Central nervous system examination. I had examined when the baby was not crying and spontaneous movement of all 4 limbs present. Preacher stage 4. Motor examination, higher mental function, no consolability and cardioability not assessed. Normal posture, bilateral upper limb in flexion and lower limb side abduction. Tone, active tone, pull to sit, vertical suspension, horizontal suspension not assessed. Passive tone, scarp sign, hand does not cross midline, popliteal angle 120 degree, ear to ear maneuver, not touch the ear. Power more than 3/5 in all 4 limbs. Cranial nerve examination, cranial nerve not assessed. 2 pupils bilaterally equally reacting to light. Cranial nerve 3, 4, 6, ocular movement symmetric and no squint. 5 trigeminal rooting and sucking present. 7 no facial asymmetry. 8 starter reflex present. 9th and 10th sucking present. 11 no head, normal head and neck movement. 12 no deviation or fasciculation of tongue. Bilateral knee jerk was normal. Bilateral plantar reflex, dorsiflexion of great toe with extension and fanning out of other toes. All primitive neonatal reflex, palmar and plantar grasp, starter, rooting and sucking reflex present. Morose asymmetrical tonic neck reflex is not assessed. Respiratory system examinations, no nasal deviations.
Can I ask you, are you able to hear me?
Yes, ma'am.
Now tell me, in the baby who is on mechanical ventilation, the baby where you have considered the possibility of, pulmonary hypertension, do we do detailed neurological examination?
Ma'am, actually, neurological examination.
The way of doing neurological examination is different. Are you going to do the, the detailed neurological examination disturbing the baby who has got pulmonary hypertension?
No, ma'am, actually, neurological examination done on 9th day when baby is stable. Otherwise, on severe pH, we cannot in PPH and we should not disturb the baby for neurological examination. Okay. Because it might worsen the PPH.
So this is this neurological status is after the baby has recovered and off the ventilator.
Yes, sir. 2 days examinations.
Fine. So you must make it clear, no? Because you are talking of examination, so you should say what was the examination on admission subsequently, and then this is what you have done probably when the baby is about to be discharged or after 7 days of life, because your diagnosis was, HIV, whether mild or moderate. This is so the neurological examination is important at discharge, in first week of life. Okay, go ahead.
Yes, ma'am. Respiratory system examination, no nasal deviation or block, no pooling of secretions, bilateral symmetrical chest rise, air entry bilaterally equal and clear, mild subposture retraction present on nasal CPAP. Cardiovascular system examination, precordium normal, apex impulse located over 4th intercostal space, medial to mid-clavicular line, first and second heart sound present, no murmur heard on auscultation. For abdomen examination, inspection, distended but soft, the skin over the abdomen looks normal, no visible bowel loops, no visible pulsation, scars or veins. Superficial palpation, no tenderness, deep palpation, liver 1 centimeter palpable, soft smooth margins, spleen not palpable, bowel sound present, and genitals normal. Summary: 9 days old female born to primary mother, delivered at full term 37.2 weeks by LSCS 2.2 kg birth weight, SGA baby with history of perinatal asphyxia with severe respiratory distress requiring invasive mechanical ventilation with mild to moderate HI, moderate pH, deranged coagulation profile, and asymptomatic hypocalcemia with normal neurological examination at present.
Okay. No, having come to end now, you must be knowing what probably was the underlying factor that predisposed this to PA, pulmonary artery hypertension and PPH.
Yes, sir.
What is the cause?
One thing is, sir, maybe due to the birth asphyxia itself, it's caused the pulmonary vascular remodeling due to the hypoxia, and it caused the increased pulmonary artery hypertension.
Now here, from beginning, the impression is that the hypoxia is not significant here. This is an elective LSCS. They have not noticed any fetal distress. Their intrapartum fetal monitoring has not given them any clues as to they should rush for an emergency LSCS. Okay, so we presume that the baby has been normal inside, but for SGA.
Yes.
Yes. This baby, did this baby show a visible wasting? Is it an IUGR? Many
sir,
times
yes.
SGA babies also, SGA babies, where you have short mother, underweight mother giving babies SGAs, but who can also be an IUGR. So you can have an SGA IUGR also.
Yes, sir. As
okay.
Is
this an SGA IUGR? Because if it is an IUGR, IUGR is one condition where you can have pulmonary hypertension very commonly. So yes, it's sir. One of the most common condition that can cause respiratory distress in thing. And because yes, of this PAH, the transition is little difficult, and this mimics as a probable mild asphyxia. Okay, yes. Here as actually here they would have definitely monitored the fetal well-being on the table of the LSCS, and they have not found anything abnormal.
Yes, sir.
Yeah. So we presume that there has not been any significant intrapartum hypoxia. Okay, and being in LSCS, unlike where there is a long duration CPD, trial labor, all that, nothing has been here.
Yes.
I think had you put the picture of the baby, probably we could help in diagnosing probably visible wasting in this baby. That could, because if this is an IUGR, then it's simple. Then this pH could be simply explained by that pulmonary artery hypertension. Okay, plain SGA babies normally don't go for pulmonary artery hypertension, and this is not a significant hypoxia to go. So I presume probably this baby did it have visible wasting.
Yes, sir.
So you have measured the centile that corresponds probably to the mother's anthropometry, and I think babies like this, you should put up a picture that would help us pick up wasting in the thigh muscles, wasting in the gluteum, wasting on the abdominal wall.
No,
cheek,
sir, there is a no visible wasting, but
so
sir,
you are sure it's not IUGR.
Yes, but sir, on integral 21 proteins, there is a head circumference on 50th centile, and on other two parameters, weight and length on lower
this
side.
is an SGA, so it will definitely SGA babies will have a slightly lesser head circumference. It's not an IUGR, no.
Yes, yes.
Yeah, but you see the head circumference is better than of other things, no?
Yes.
Yeah. So this is probably an SGA going in, slipping into IUGR, I think, with placental insufficiency. That probably may be the cause for all these findings. This placental insufficiency that comes very late may be the reason for the hypoxia event at birth, and also the pulmonary artery hypertension.
Yes.
Do you have any details on placental examination? Did means the referring hospital gave you any details of placenta?
No, ma'am.
Okay, fine. Okay, tell me now, you know that how do you, what are the prognosticating factors in perinatal asphyxia? Can you define perinatal asphyxia first?
Ma'am, there is a three definition. According to according to WHO, there is a failure to sustain and initiate breathing. It is a perinatal asphyxia. Another definition is a NNPD definition, which shows that if at if 0 to 3 Apgar score at 3 minutes, which shows that mild to mild Apgar.
No, which definition are you following in your unit?
Yes, yeah, ma'am. ACOG and app definition,
which shows that
definition. Yes, ma'am. Ma'am, we showed that the at 5 minute Apgar score is less than 5, and pH is less than 7. Base axis is more than 16, and any abnormal neurological parameter like seizures, baby had seizures, comatose, lethargy, and ma'am, seizure.
Any other parameter is there? What about multi-organ dysfunction?
Yes, ma'am, and multi-organ dysfunction.
Yeah. So, so if this criteria are satisfied, then you are going to say that the baby. So now tell me the prognosticating factors for perinatal asphyxia, and these are important. Tell me clinical and don't start with MRI. Tell me the prognosticating factor right since birth of the baby.
Yes, ma'am, one thing is Apgar scoring. If Apgar score is a persistently low at 10 minutes, less than 5, it is a prognosticating factor. Another thing is failure give IPPV at up till 1 hours after the birth. Then it is also a prognostic factor. Another thing is the cord blood ABG pH is less than 7 at 1 hours.
Oh,
And,
clinically itself. Apart from Apgar, clinically, madam is asking mainly
yes.
clinical.
One thing is Apgar, then
the time taken for spontaneous breathing to get established or crying to come. Okay.
Needs of IPPV.
Sorry?
Needs of intermittent positive pressure ventilations.
Rates.
Then time to start feeding, then
Time
convulsions. Okay.
Yes.
So these are all some of the clinical prognostic indicators.
You have even when you do an HI staging, you have HI staging, which is 3. This is, you have, the neurological outcome is going to be not optimal and the baby will have problems. Even oliguria, a simple bedside parameter of monitoring urine output. Oliguria in first 36 hours of life is shown to be associated with, the neurodevelopmental impairment in the baby. So these are basic. Then the refractory seizures, you have forgotten the seizures. The baby getting convulsions, the refractory neonatal convulsions are again, indicates the poor prognosticating factor. The baby who remains in HI stage 2 for more than 5 days. So you have HI stage 3 in the baby. The baby who remains in HI stage 2 for more than 5 days is again a poor prognosticating factor. And the baby is neurologically abnormal at discharge or day 7 of life is again a poor prognosticating factor. So all these factors, will help you that when you are counseling the parents in the labor room, when they get admitted in it, the baby gets admitted in NICU, these are all the factors which will actually help you. And then you have, the certain investigation, and then you have neuroimaging. So depending upon that, putting everything together, you can give the prognosis to the parents. Okay.
Yes, ma'am.
Okay.
Are there any questions in the chat box?
Yeah. Or do you have time? Do we have any questions in the chat box?
There are mainly 2 to 3 questions in the chat box. Jaimin, first you can try and answer those questions, and if you can't answer, then we can ask either Ruchi ma'am or Arsar sir. So the first question is from Dr. Ronak Patel, that is there any relationship of the severity of hypoxic ischemic encephalopathy and duration of cord prolapse?
Cord prolapse.
Any relation of severity of HIE? And
that depends on not cord prolapse alone. How much is the cord getting compressed and how long? How long the intermittent hypoxia the baby is subjected to is important. Purely not cord prolapse. It's the cord compression that may happen with prolapse that probably predisposes. The longer the compression, intermittent compression, the greater will be the neonatal injury, fetal injury.
Yeah, and other thing is, see what you have to remember with cord prolapse or cord compression is that there is no time for the diving reflex to happen. So this is one of the condition, this is that normally, that there is a diving reflex and there is every attempt to, preserve the brain function. But there is in cord prolapse, there is no time for the diving reflex to occur. And that's why what are the first, the organs which are going to affect it is the structures in the brain perfused by the posterior circulation. So you can have, this is called as a near total asphyxia. So that is the importance what you keep in mind when there is a cord prolapse. Fine. The next question?
After that, there are only 1 or 2 questions related to the case. One of them was what were the indications for LSCS? So Jaimin has already mentioned that this was an
CPD.
delivery outside, and
No,
there
it
was
was
a
CPD. I think it mentioned as CPD.
Yes, sir. There was a breech and cephalopelvic disproportion.
Yeah,
These were the 2 indications.
Primary
And-
breech CPD.
Yes, yes.
Yes,
Then
ma'am.
there was
Yes,
a
sir.
question about whether baby had seizure or not. So baby did not have any conversion. And whether hypothermia treatment was given to this baby. Again, this baby was received at 26 hours of life, and we in periphery no hypothermia was given. So I think that's all about the questions in the chat box. So I think from whatever was Jaimin's presentation and from the various questions that were asked by Madam and Sir, I mean, there were very few important things were discussed, like why it is important to differentiate between mild to moderate HI at the time of birth, and then the importance of mother's height along with the weight and body mass index is very important antenatally to assess. When we see any baby where mother is O negative, we should also ask about the blood group of the husband. And then, if a baby has been delivered via LSCS, and if mother is not in the labor pain, then how can it affect the babies? So these were the important things that were discussed. Along with that, as Madam asked, important prognosticating factors which can help us to decide about the prognosis of such babies, clinical as well as the other parameters. So these important things were discussed. Now I will hand over to Dr. Prashant.
Thank you
Jaimin,
so
you have
much.
done a good work. Thank you.
Yeah.
So that is what I was going to say, sir, that before
Yes.
I thank everybody, we just want to make an announcement that Gujarat NNF is hosting 3rd West Zone Annual Conference of NNF and 19th Annual Conference of NNF Gujarat on 26 to 28 August at Udaipur Hotel in the Residency. So those who are present, please register. That will boost our confidence. And now coming to the main point of today, that thank you so much, Jaimin, that you have actually presented a case which is a live case and presented almost all the things. So NNF Gujarat presents a certificate of appreciation to you. And we are thankful to Dr. Ruchi Nanavati ma'am for being an expert, as well as Dr. Arasar Siralar sir for being an expert. I also thank Dr. Reshma Pujara for being the chairperson and conducting the case in time limits. We almost finished in time. So thank you so much, everyone. And to all the participants who are present, every Wednesday we are having a Neonatal Pathshala, either a PG case presentation or a seminar or a panel discussion or a quiz. Same Zoom link, same YouTube link. Today on Zoom we were having maximum of 74, and on simultaneously on YouTube there were 27 participants. So Jaimin, congratulations for a century of participants.
Thank you, sir.
Yeah, congratulations, Jaimin.
I just wanted to share, I think Dr. Gautam Suresh is in the audience. I'm not sure if he's the one. Maybe if he can speak.
Kanekal Gautam is there, sir.
I think he.
So I just made it. Actually, I now everybody can unmute themselves. But sir, Dr. Gautam sir, if you're
yes,
there.
I'm listening. Thank you.
Yeah.
Sir, can you comment, because you've been there from the beginning. I saw you from the beginning.
No, I think it was an excellent presentation by Jaimin and good debriefing and teaching by the teacher. So I enjoyed getting a refresher. It's good to go back to the basics.
Thank you, sir.
Thank you, sir. And I think sir's book on ventilation is just out, 7th edition. We just saw the messages. This on neonatal ventilation. Dr. Gautam Suresh and Martin Kessler. It's just out, and I'm sure we have access to it on Clinical Key, but others can buy the book. Thank you, sir, for joining.
Thank you. My pleasure. It was a great session. Thank you for inviting me.